Thank you, Ross. You can still call me Dr. Bentley. It's perfect. So it's nice to have a radiologist here. Thank you. I counted 15 radiology insults in the prior session. I'm going to try to do 16 surgical insults. So.
I think you can do it.
Which one?
The green button is got it. Big one.
These are non-relevant. These are clinical research organizations I consult for. So why image the patient? I just throw this video in. It has nothing to do with anything. Yes, I just saw endoscopic videos. I thought I need my own video. So I did it. We do it for pathological information. We do it for anatomic information. We do it for physiologic information. And let's be honest, we did it because radiology hedged. I don't use the word equivocal. I would not use clinically correlate. I would not so consistent with. I will tell you what it is. That, at least at Columbia, that's what we try to do. So when we look at the CT, we already know CT contains a large amount of data. And we can change how we represent that data, but it's replete with data. So on this image, this is just from an abdominal CT, same image, exactly the same data, and it comes relevant later. If you look at the density, it's fat, so it's always minus 111. We can change how pretty we look at the picture, to look at the lungs, the bones, but fundamentally it doesn't change. But what is radiomics? Well, there's more, picture speaks 1,000 words. Now there's actually 10,000 words from the picture. It's much more than an image or scan. There are a large number of features that we can take from routine clinical imaging, and this vast amount of data has been used in a vast amount of settings. Response to chemotherapy, changing chemotherapy early, long-term cardiovascular risk, and also assessing surgical risk and assessing post-surgical recovery risk. So it is an objective measurement. It can be used across modalities. I'm going to focus mainly on CT. It's one of the workhorses, and we're dealing with surgeons, so you guys use CT, especially in sort of body imaging is what I do. It's reproducible. It can be semi-automated, and we're moving to an automated manner, so we actually have to do nothing. And it's retrieved from routine clinical imaging. So they've coined the phrase opportunistic CT. The CT is already done. Your patient's coming to see you, they're getting the surgery, no worries, we can use that data. And we can follow the patient. If the patient's being scanned for whatever reason, at any time we can extract that data. So we can look at pre-surgical, post-surgical at any point. Radiomics and surgery, it continues to grow. And when Debbie asked to do, I immediately Googled radiomics and surgery, and you can see that it's uptailing. It's critical for the care of our patient, and this is both in endoscopic surgeries as well as other types of surgeries. So I'm going to talk about a few of the morphological parameters that can be maintained, and I'll talk more about some. We contain bone mineral density from the CT. I'm not going to say anyone is older in this room, but those who have had a DEXA scan, we can do a DEXA scan, but there's much more information that can be obtained from the CT. We can do aortic calcium score, and it is a better predictor of cardiovascular risk than other clinical criteria. And we can assess fat. We can assess visceral fat, subcutaneous fat, liver fat. We can also assess muscle, how much muscle the individual has, and more importantly, what is the density of that muscle. So a lot of papers have used threshold. What is sarcopenia? What is too much visceral fat? What is too little visceral fat? What's too chubby? What's too weak? Every study has different criteria. And even the same study looking at the same patients have changed their criteria as they've gone along. So I'm going to try to skip what the actual thresholds they have used, because it's going to be, pancreatic surgeon may think a different threshold than a colon surgeon and so forth. And it's better to think of it as a continuous variable. Clearly, any bimodal distribution of that person has too little muscle mass or too much fat doesn't take into account cultural differences, gender differences, race differences, and all that type of stuff. So I will just discuss what we can get, and the actual parameters, I can happily email you some reference material as well. So fat assessment. We know that abdominal or visceral fat is an important factor in cardiovascular assessment. However, it is not easy to measure visceral fat clinically. I go to see my doctor. He makes me stand on a scale. He tries to find a tape to go around me. I walk out in disgust. He doesn't know how much visceral fat I have. Fatty liver, not easy. We know fatty liver is a problem. We know NAFL and NASH are all significant health factors. We cannot get that from a purely clinical assessment. Visceral, subcutaneous, and hepatic fat can be easily extracted from cross-sectional imaging without the need for a dedicated scan. We know we can do a quantitative assessment of visceral to subcutaneous fat ratios. Population studies have shown sex-based differences between this visceral to subcutaneous fat ratio. A group out of Wisconsin looked at the colon cancer CTs for regular colon cancer screening. The ratio was 1.8 in men, standard, 0.6 in women. So clearly there's a difference, and this difference can be extracted from data obtained for other reasons. So this is an example. So this was taken from the Wisconsin paper. And I just learned this, I have to say, so no yelling. There's the apple-shaped configuration, and there's a pear-shaped configuration of the body habitus. So in this case, this patient, the blue is the visceral fat. This patient has much more visceral fat in relation to the orange, which is subcutaneous fat. In this patient, they have much more subcutaneous fat, which is orange, compared to the visceral fat, which is blue. And the middle patient is in between the two. The important thing is the radiologists did nothing to obtain, the researchers did a lot to obtain this data. The radiologists now, data's there for you, it's immediately available. This was a paper at a project we did at Columbia looking at visceral fat and subcutaneous fat in patients treated with esophageal cancer. And although we talk, and I'll cover it in a bit, we talk about visceral fat and this fat and sarcopenia, obviously everything is related. So this software we have at Columbia is semi-automated, which means it does it automatically, and then some numbskull likes me double checks and say, yes, indeed, you have correctly isolated it. So in the first patient, mouse. Oh, I see, yeah, okay. Oh, there. So in the first patient, the patient has normal subcutaneous fat, normal amount of muscle mass. Second patient has normal amount of muscle mass, less amount of subcutaneous fat. This patient has a lot of subcutaneous fat, has less muscle, and the last patient has less of both. This data, once again, this scan was done in patients undergoing routine screening for esophageal cancer or follow-up. This data was extracted from it, and this was completely automated, except the fact that we checked it. But this is part of this was done a few years ago, and this is part of the research. And we've also done this also in patients recovering from colon cancer as well. And to just show how nothing is that easy, so actually in this case, subcutaneous fat, actually a high amount of subcutaneous fat, so what they call a subcutaneous adipose index, actually was predictive of a better response. So more subcutaneous fat was predictive of a better response. And I'm not showing this because I want to talk about esophageal cancer, only to show that there is variation in what the data means, and the data needs to be applied specifically to the disease. It outperforms BMI in future cardiovascular risks, and it can also be combined with other features, namely muscle. So CT is very good identifying muscle. We always do it at the L3 level because we get the paraspinals, the psoas, and the total muscle mass. We measure both the density and the bulk of the mass. So in this case, the psoas surface area, paraspinal density, total muscle mass, easy. 2 seconds, press a button, it's done. And it's not also how big it is. The bigger muscles aren't always important, it's how dense the muscles are. As there's fatty infiltration of the muscles, you may not see it overtly, but you see the density decreases. And muscle density has been shown to be a better biomarker for adverse outcomes, such as fractures, cardiovascular events, than just the muscle mass itself. And being low muscle density, low muscle mass, high visceral is not a good thing. Hepatic steatosis, I'll end with. MR provides much better information. If you need fat quantification from your patient, your routine MR will do it. CT is getting there, and now ultrasound, new technology, actually allows for a quantitative assessment of amount of fat within the liver. So there is, unfortunately, a great deal of variability in CT technique, and these small variations in technique adversely affect Hounsfield units, which means you can't put these thresholds in. It's still not in widespread clinical use. There are no FDA-approved software that's used. And I'll skip this. There's a wealth of information to wrap up that can obtain. We know you want to reduce your vascular counts. You know muscle mass, muscle density, visceral fat, subcutaneous fat, and hepatic fat. All are important and all can be measured in a retrospective way. A lot of work has been done on predicting response to treatment. One time point, how will they respond to surgery? How will they respond to chemotherapy? Very little work has done on prehabilitation on these morphological factors. Is stuff that we're doing to optimize the patient for surgery actually making a difference in that patient? Now, if you are doing prehabilitation, which I'm saying 3 times because I actually looked up the word 3 months ago, I'm a radiologist. I don't go to the gym. If the patient is getting scanned anyway, use the scan to get the data. And hopefully within the next short period of time, this will be routinely clinically available. Thank you.
Thank you so much.